Hello, everybody. Thank you for stopping by my poster. This is a poster presentation for AABB Virtual Annual Meeting 2021. The title of the poster is Benchmarking and Process Improvement in Blood Banks, a multi-center approach in Saudi Arabia, presented by me, Dr. Nashwa Said. All authors declare that there is no conflict of interest. Purpose and objective. Transfusion medicine is a high-risk practice that requires a regular quality assessment, effective benchmarking, and partnerships to address common challenges and establish proper corrective actions to achieve the needed goals. Benchmarking is an essential quality improvement tool in transfusion medicine that helps in recognizing areas for improvement and establish achievable targets. It can be national, regional, or international endeavor. In the absence of national benchmarking system, an institution can follow international benchmark or may collaborate with peer institutions to compare various key performance indicators along the transfusion chain. 3 nationally accredited hospital-based blood banks from 3 different cities in Kingdom of Saudi Arabia, referred to Center A, B, and C, collaborate in this study by analyzing the data related to selected KPIs, looking into variations in practice, understand the factor behind it, and identify areas for improvement for each center. Methods. In this retrospective study, the data related to blood donation services, cross-matching to transfusion ratio, and blood components wastage were collected for 1 year starting from 1st of January to 31st of December 2020. The source of data were hospital information system and blood bank documents. The selected KPIs were identified based on the common practice in the 3 centers. Results. This graph demonstrates a comparison between the 3 centers as regards the number of blood donors. For the number of registered donors, Center B and C are almost have an equal number. However, the number of accepted donors in Center B is more than Center C. If we compare the rejected blood donors, we can see that Center C has the highest number in relation to the other 2 centers. These 2 graphs show the segmentation of blood donors. Graph number 2 shows the percentage of volunteer and family replacement blood donors. We can see that more than 50% of Center A donors are volunteer donors, while Center B and C have the majority of their donors from family replacement. From the donor gender point of view, Graph 3 shows that all 3 centers have a small number of female blood donors. However, Center B has the highest number, equal to 827 female donors. This graph presents the cross-matching transfusion ratio. We compare the cross-matching transfusion ratio in general and specifically for surgical cases. The CT ratio was within the acceptable ratio for the 3 centers. However, it's variable for surgical cases. Center A showed the highest ratio, 3.1, while Center C showed the best ratio, 1.3. These 2 tables illustrate the blood unit wastage. Center A has the highest percentage of wasted unit, 13.2%. Center B has a low percentage, 1.8%, and Center C in between with 6.3%. The most common cause for unit discard was reactive screening test for transfusion-transmitted disease markers. The percentage are nearly equal in the Center A and B. However, Center C has the high percentage, 83.6%. Discussion. Center A has more active mobile blood donation drive, which explains the highest percentage of volunteer blood donors compared to Center B and C, which have fewer mobile blood donation campaigns per year. In general, Cross-match to transfusion ratio in within acceptable target less than 2 for all 3 centers. However, it is variable for surgical cases. The variability of surgical CT ratio illustrates different approach of hospital-related practices, including the implementation of maximum surgical blood ordering schedule. The total number of wasted whole blood and RBCs units was higher in Center A compared to Center B and C. The percentage of discard due to reactive transfusion-transmitted disease markers vary among the 3 centers. That may be partly explained by possible variable prevalence of transfusion-transmitted disease in the different Saudi cities or regions. Summary and conclusions. Comparing the practice of local blood bank centers can be a base for proper benchmarking that may contribute to improve the current transfusion practices. There is a critical need to set national guidelines, including predefined KPIs and standardized data collection methods. To achieve the needed improvement, auditing the practice and implementation of effective hemovigilance system are recommended. Finally, we acknowledge the valuable efforts and great support of blood bank staff in the participating 3 centers. Thank you.